Risk assessment of suicide includes the importance of identifying the intent behind the self-injurious behavior, as well as the severity and lethality of the behavior. Distinguishing between suicidal and non-suicidal self-injury can be challenging, as there may be overlap in the behaviors and motivations for engaging in them. One key factor is intent. Suicidal self-injury is done with the intent to die, while non-suicidal self-injury is done with the intent to relieve emotional distress or communicate distress to others. Another important factor is lethality. Suicidal self-injury is typically more lethal than non-suicidal self-injury, and may involve methods such as hanging, shooting, or jumping from heights. Emotional regulation is often a key motivation for non-suicidal self-injury, as individuals may use self-injury as a way to cope with intense emotions or to gain a sense of control. In contrast, suicidal behavior is often driven by feelings of hopelessness and a desire to escape emotional pain. The demographics and clinical characteristics of those who engage in suicidal versus non-suicidal self-injury may differ. For example, females are more likely to engage in non-suicidal self-injury, while males are more likely to die by suicide. Culture can also play a role in distinguishing between the two, as some cultures may view self-injury as a form of spiritual or religious practice rather than a sign of mental illness. Examples of non-suicidal self-injury behaviors include cutting, burning, and scratching oneself, while of suicidal behaviors include overdosing or self-harm that involves significant blood loss. When assessing self-injury behaviors, and should consider multiple factors in distinguishing between suicidal and NC, in order to develop appropriate treatment plans and interventions. Some important points and examples regarding suicidal risk assessment include an understanding of suicide risk factors and warning signs, and the ability to develop a comprehensive risk formulation that incorporates relevant clinical information. Family and twin studies suggest that genetic factors play a role in suicide risk. Some genetic markers may contribute to suicide risk, such as variations in the serotonin transporter gene. Neurobiological factors that may contribute to suicidal behavior include alterations in brain emotion regulation region and neurochemical imbalances such as serotonin, dopamine, and glutamate. Genetic variations may influence the way individuals respond to stress, which could contribute to alterations in the neurobiological systems involved in emotion regulation. Interventions that target the underlying genetic and neurobiological factors may be more effective in treating suicidal behavior than those that only target cognitive or behavioral factors. Cognitive and information processing approach. Cognitive factors such as hopelessness, perceived burdensomeness, and thwarted belongingness are associated with suicidal behavior. Research on cognitive theories of suicide suggests that suicidal behavior is related to negative cognitive states and perceptions of hopelessness. Information processing biases such as attentional biases, memory biases, and interpretive biases are associated with suicidal behavior. Alterations in the prefrontal cortex may underlie information processing biases in individuals who are at risk for suicide. Negative cognitive states may contribute to information processing biases, which could in turn contribute to suicidal behavior. Interventions that target cognitive and information processing factors may be effective in reducing suicide risk. Freud suggested that suicidal behavior may be a manifestation of unresolved grief or loss. He also proposed that suicidal behavior could be a way of expressing anger or aggression towards oneself. Contemporary psychodynamic theories of suicide, attachment theory and object relations theory, can be used to understand the role of interpersonal difficulties and insecure attachment in suicide risk. Research has shown that individuals who have a history of trauma, neglect, or abuse may develop internal representations of the self and others that are negative and self-critical. This negative self-schema may increase the risk of suicidal behavior by contributing to feelings of hopelessness, worthlessness, and despair. Interpersonal theory suggests that suicidal behavior is most likely to occur when a person experiences both perceived burdensomeness and thwarted belongingness, i.e., feeling disconnected from others. Unconscious motivations, such as guilt, shame, or aggression, may contribute to suicidal behavior in some individuals. Interventions that target the underlying psychodynamic factors may be effective in reducing suicide risk. For example, psychodynamic therapy or psychoanalysis may help individuals to explore and resolve unconscious conflicts that contribute to suicidal behavior. The three-step theory of suicide. Suicidal behavior involves a progression through 3 stages: 1. Perceived burdensomeness, 2. Thwarted belongingness, and 3. Acquired capability for suicide. The third stage refers to an individual's increased ability to tolerate pain and engage in suicidal behavior due to repeated exposure to painful or traumatic experiences. The integrated motivational volitional model of suicidal behavior. This model combines elements of both the interpersonal theory of suicide and the three-step theory of suicide. Here, an interaction between predisposing factors, for example, genetics, personality, proximal factors, for example, social support, stresses, and volitional factors, attitude, ability, and carry out suicide. Core competencies. Suicide risk assessment requires a range of skills and competencies, including the ability to build rapport and engage in collaborative, non-judgmental communication with the patient. Risk framework is for assessing suicide risk that includes information about presenting problem, assessing risks and warning signs, current risk, developing a risk formulation, and a safety plan. Warning signs provides a list for suicide risk, including changes in mood or behavior, hopelessness, substance use, self-injurious behavior, and giving away possessions. Safety planning emphasizes the importance of developing a safety plan with a patient of impending suicide as part of the risk assessment process. The safety plan should include specific strategies for managing suicidal thoughts and behaviors, as well as contact information for crisis resources and emergency services. The importance of conducting a thorough suicide risk assessment in clinical practice, taking into account both clinical and contextual factors that may contribute to suicide risk. By developing core competencies and utilizing a comprehensive risk assessment framework, mental health professionals can effectively identify, manage, and save a patient with suicide risk. Psychological treatments. CBT is a widely used treatment for suicidal behavior that focuses on identifying and challenging negative thought patterns and developing coping skills to manage distress. Here, a patient to identify and challenge negative beliefs about themselves and their future, and teach them coping skills such as relaxation techniques and problem-solving strategies. Dialectical behavior therapy, DBT. DBT is a treatment that combines elements of CBT with mindfulness and interpersonal skills training. Here, a patient mindfulness exercises to help them stay present and non-judgmental in the moment, or work with them to improve their interpersonal communication skills. Psychodynamic therapy. Psychodynamic therapy focuses on exploring the underlying emotional and interpersonal issues that may contribute to suicidal behavior. Here, a patient to explore unresolved trauma or negative relationship patterns that may be contributing to their suicidal thoughts and behaviors.